Okay, so let's talk about diseases of the myocardium. This is kind of a light one, along with the other one, and then we'll get into some general things, which is a little bit more detail. All right, so myocarditis, okay? It could be due to a certain virus called Coxsackie virus, okay? Or rheumatic fever. Certain medications and chemicals can cause this too. The symptoms is, it looks like heart failure, all right, but it's not. Or it can cause arrhythmias. Usually, most have a good prognosis. They usually will just be self-limiting, get rid of the virus, and it's fine, okay? The more severe ones, and about 30% of these, will actually go to something called dilated cardiomyopathy, which we'll talk about. So the heart gets very big and very thin, okay? But most cases, it's nothing really to worry about. But a third, that's a pretty big number. So we like to just watch this and make sure that, you know, people have rheumatic fever. The people that have rheumatic fever, they'll be watched for the rest of their life, okay, because of all the different valvular diseases that would happen. They would have to probably get valve replacements and whatnot. Okay, so that's what that is. So cardiomyopathies, though. There's 3 different types. The most common type is dilated cardiomyopathy. About 90% of all our cardiomyopathies are those. We also have hypertrophic cardiomyopathy, and I added this little line over here that wasn't on the canvas. You might want to just add that on there. I'll fix the canvas later on. But that's hypertrophic cardiomyopathy, and then the rarest one we don't see as much, something called restrictive cardiomyopathy. Okay, and we'll talk about each one of these. Now, cardiomyopathies could either be primary, and it's usually genetic, but we don't know what the cause is. They're idiopathic. Okay. Secondary, it could be secondary to high blood pressure, valvular disease, ischemic heart disease, a lot of different causes, okay? Complications, they could cause arrhythmias, all right, irregular heartbeats, heart failure, and most deaths because of this are usually sudden. This is a story where you hear someone, you know, a young person at like 24 years old dies of a heart attack. He doesn't do any cocaine, he doesn't drink. You know, where did this come from? It's usually these kinds of stories, okay? So we have 3 different types. The most common one we have over here is dilated cardiomyopathy. Alcohol is a very common cause, but please don't think that that's the only cause. There's a lot of other causes. But if you see someone who is 22 years old and has a heart attack and you know he was drinking, you're probably thinking dilated cardiomyopathy. But that doesn't mean the only reason for that. What happens here is that the heart itself gets thicker and dilated. So what will happen is the heart is going to get bigger, but the wall of it is going to be thick. All right? So it's a little bit different on that one. They usually have a weak contraction. So because it's so dilated, it can't squeeze. As much as the heart has hypertrophy on it, it's not enough muscle to squeeze the blood. So they tend to have a weak contraction. CTX is contraction. And when you have a weak contraction, you're going to have a decrease in ejection fraction. Right? The amount of blood that comes out is going to decrease. They usually will have a poor prognosis. 75% will die after diagnosing of this within the first 5 years. They need to have a heart transplant. It's the only way that they're going to survive this, because the heart is just not going to work. Okay? So that's dilated cardiomyopathy. We have hypertrophic cardiomyopathy, and in a case like this, the heart itself is not dilated, it has a thickness that's going on there. Just the hypertrophy that's going on. It resists filling. What will happen here is if this is the heart, and let me get this out of here. So it's now normal valves. But we're now going to make the heart very thick. Normally this would be thinner, okay? So what will happen here is that this is going to fill, but it's going to resist because it's much smaller. So there's going to be more pressure up here. Does that make sense? Because it's so thick. The cavity got smaller. Okay? What will happen here is that normally we could fill this up at the end of diastole. Normally this would fill, but we're going to have less blood going into the left ventricle, which means the volume at the end of diastole is going to, it's going to end diastolic, end diastolic pressure. So that's right. So the volume, the end diastolic volume will decrease, but because this is so thick, the pressure is going to be very high. Does that make sense? So this is correct. End diastolic pressure will increase because you can't get that much blood in there. So it's trying to squeeze an extra drop, but there's so much pressure in there. But we have a decrease in end diastolic volume. Does that make sense? Pressure, volume, okay? And that, since the blood can't go into the left ventricle smoothly, there's a smaller cavity here. There's going to be a backup of blood here. There's going to be a backup of blood in the lungs. It's going to cause lung congestion, lung pulmonary edema, which can lead to right heart failure. Right? All right. So you get this strong, forceful contraction, but there's going to be less blood that's going to go out there. So your stroke volume, even though it's going to push all that blood into the aorta, there was very little in there anyway because of this cavity being small. The classic scenario is that 18-year-old playing baseball, he has a heart attack on the field. This is why we do, and he probably, when he went to high school over here or grammar school, to make sure that this person, your child, is ready to play baseball or tennis or softball, whichever, the doctor has to listen to the heart. Because these are the incidental findings. We don't realize, you don't know that you have this issue until you exert yourself. All right, so that's why it's routine that doctors need to check as they go into the schools, and they screen everybody to make sure that their heart's okay. So that's what happens. They usually have these sudden deaths in these athletes, young athletes. All right? And the other one, which is very rare, but restrictive cardiomyopathy, is that the ventricle itself is very stiff, and it can't really contract. It just fills incompletely, and it can't expand really. So it resists filling. So we're going to increase the end diastolic pressure, just like we did over here, which will lead to lung congestion, right? Congestive heart failure is the usual outcome because the blood can't move forward, all right? So there's going to be a decrease in the stroke volume, which means there's less blood going into the coronary arteries, and that can lead to congestive heart failure. Okay, questions on that? All right, this is another quick one over here. Is pericardial diseases. Okay? Pericarditis. So it's really two diseases we're going to talk about here. Pericarditis is always secondary to some other cause. How much do you have about
this? This class can last all night.
Okay.
I don't.
Okay. He's in with me. No. Okay. Anyway, so pericarditis, it's always due to some other cause, okay? It doesn't just happen. Most common cause of this is myocardial infarction. There's going to be serious fluid that's going to go out there. Pericarditis is basically the pericardium, the sac that the heart sits in. Question? Oh. So what will happen is, if this is your heart, the pericardium is the area, it's a sac that's going around the heart. Now, this pericardium usually will sit right next to and lie right on the heart muscle itself. What we're talking about is pericarditis. This is going to get a little bit thicker, all right? The pericardium is getting thicker, it's inflamed, and in between here, we're going to fill it with fluid. All right? Because it's inflamed, it'll have inflammatory cells, you'll have the water, all those cardinal signs we talked about with inflammation. Fluid will go in there, so serous kind of fluid. But there could be blood in there, there could be other things. But the most common cause is myocardial infarction. Serous fluid will go into there. You could have RF. What's RF? Rheumatic fever, right? Rheumatic fever. Okay? You could have lupus, renal failure, cancer, bacteria, a bunch of different things on here. And the fluid that's in there could be a lot of different things. It could be fibrinous, all right? This is the most common one, non-infectious, fibrin-rich. It's usually because of the myocardial infarctions, fluid's going out there. Serous over here, that could be myocardial infarction also. Pyrulent, pus, right? Bacterial. Hemorrhagic, hey, if someone actually got a stab here, you're going to have blood that's going to start building up in here. If there's a clot where the stab is, then this is going to build up with blood in here. And the caseous is very rare, but that's when TB happens or fungus. Usually we'll get atypical chest pain and a friction rub. Now, friction rub could happen on the heart, but also in the lungs. And what it sounds like is you listen to the heart, and you hear the heart beating, but you also hear this. The best way I could explain it with what's outside is like you're stepping in snow. Boom, boom. I mean, you guys understand what I'm talking about. But if I did this class in Hawaii, they would, right? So it's that sound, and I'll talk more about friction rubs when we deal with pleuritis with the lungs, because that's also a sound like that. So when you listen to it, it sounds like, we call it a friction rub. So if you hear friction rub and you hear it's happening with the heart, think of, if you see that in like a case study, and they say that there's a friction rub, it's either going to be pleuritis, and that's lung kind of stuff, or it's going to be pericardial or pericarditis. All right? So that's what happens with that. And you could go through each step over here about the effects of pericardial effusion. I'm not going to go, but it's step 1, step 2, and it builds that whole thing. Okay? Now, cardiac tamponade, okay, goes with this also. What's going to happen here with cardiac tamponade is a compression of the heart by fluid in the pericardial sac. Same thing here, okay? But what happens here is blood that usually goes in here. So some kind of trauma. Blood is going to go in here, okay? It could be also due to a serious fluid like congestive heart failure. Let's say there's something over here where blood is, I don't know, let's say a stab, and it hits, let's say, the muscle of the heart, but it doesn't stab into the chamber. What will happen is blood is going to start filling up into the sac. Does that make sense? Right? So this sac is going to get more, and it's going to go further and further away from here. But what's going to happen is the blood that's in here, since the sac has there's a fibrous tension in it, and it can't stretch all the way. It gets to a point where it can't stretch anymore. So what will happen is this will fill up with blood, and now there's going to be a lot of pressure on the heart. And what will happen is the chambers of the heart are all going to equalize in pressure. All right? What will happen here is it's going to compress on the heart. All this blood over here is going to compress on the heart. Now the heart can't fill because it needs to stretch. So the left ventricle is not going to fill with blood because something's holding it back. It's kind of like if I take a balloon and I'm trying to blow up the balloon with air, I can do it no problem. But if someone's pressing on the balloon as I'm trying to get air in, I can't fill that balloon up. So if someone's pressing against the pericarditis, or let's say the cardiac tamponade is pressing against this, you can't fill that left ventricle properly. So that means it's going to decrease the amount of cardiac output of the heart. Okay? And they usually will have the pressures in each one of these chambers is going to be equal. Because it's not just pressing on the left ventricle, it's pressing on the right ventricle, the left atrium, the right atrium. So each one of these chambers is going to eventually equalize in pressure. Because it's all around the heart. Does that make sense? Okay? So it's fatal if it's not corrected immediately. And how do you fix this? Well, we got to find the cause, okay? But what they'll do is something called a pericardial window. They'll do surgery and they're going to open up here. And we're going to then take out, so you're making this little window, pericardial window, and then you're going to take out all the blood that's in here and then go to wherever the injury is and fix it. All right? Because what will happen, you've got to increase the cardiac output. You just have to do that. Once you remove the blood here, now the heart could expand and fill. Okay?